speak about surgery, okay? So
now we are on YouTube. Now we are also okay. Yeah, but you know, the hepatologists are the ones who send us the patients, so we gotta invite them too. Otherwise, I'm not gonna have patients to operate. Just trying to contact him. Ah, there he is. Oi, Jean, tudo bem?
Tudo bom, João?
Okay. We have all the speakers now on the screen. I'm going to introduce you all. So this is Dr. Jean Tafarel, professor, actually. He's the coordinator of the School of Medicine at the Catholic University here in Curitiba. He does a marvelous job there. And at the same time, one of the top hepatologists of the city as well. I don't know if you know other people, but Olivier Scatton, a former resident in Paris, we were resident together back in 1998. Le meilleur. Marcelo Bruno, who is a surgeon at Albert Einstein Hospital, and Felipe Coimbra, oncology surgeon at the Camargo, former HPB, from the American chapter HPB College of Surgeons president.
Hello, João.
So that's the team, the dream team.
You are the most important guy here, João.
Huh? What did you say?
Yes, João Tafarel is the most important guy here, right?
Oh, sure. He's the one who finds the patient to be transplanted and resected.
I'm here to learn with you.
So the idea was probably the speech, the presentation is going to last, I don't know, Olivier, about 40 minutes, something like that.
Yes, you asked me for 40 minutes. Okay,
yes, you feel free to all your questions, and people who will be watching, they're going to be on YouTube, and I'm going to be seeing the questions, and I'm going to give it to you up to a certain limit. We're trying to keep everything, your presentation and the question discussion, 1 hour and 10.
Okay.
For us, it's 7 p.m. For you, it's midnight. So
that's okay. I have an easy case tomorrow. Don't worry.
Thank you. Thank you very much. So it's 7 p.m. We are trying to keep the schedule.
Okay.
She just gonna ask her if we can start it, and then we go on. Okay, she said yes.
Okay.
Well, so we are gonna formally start this presentation. Just would like to say good evening to everybody who is watching us tonight. It's a pleasure for us to be here. I'm Dr. João Nicoluzzi from Angelina Caron Hospital at Curitiba. This is the HPB 21, a course dedicated to the diseases of the liver and pancreas, its surgeries, and even transplantation. I would like to thank to people who are attending this online event. We are extremely happy to have more than 2,000 people who have enrolled for the HPB 21. It's very, very nice. Thank you very much for everybody who is attending this course. Thank you as well to the different societies that are supporting us, like the Brazilian Society of Surgical Oncology, that Felipe was also a former president, the Brazilian College of HPB Surgery, the Brazilian College of Surgeons, to the many student surgical groups, and thanks to Angelina Caron Hospital, which is the place where I work, and I've been working for the last 21 years as well. So I would like to introduce you all the authorities and speakers who are with us tonight. I would like, first of all, to introduce you Professor Jean Tafarel. Professor Jean Tafarel, he's one of the best hepatologists in the country, and he also coordinates the Catholic University Medical School. For me, an example to students and residents around him because of his inspiration that he does on a daily basis. Congratulations for the way that you are forming those people and the way that you inspire them. I'm witness this almost every day. Thank you.
Thank you, João. You're my friend. You live in my heart.
Welcome here tonight to the HPB 21. Professor Marcelo Bruno de Rezende, one of the best HPB surgeons in the country as well, works at Albert Einstein Hospital in São Paulo, and with a huge experience with liver resection and liver transplantation. Professor Bruno, welcome here with us tonight as well.
Thank you, Nicolosi. Pleasure for me.
And last but not least, Professor Felipe Coimbra, HPB surgeon at the Camargo Hospital, former president of the American chapter of the HPB Society, and who also performs in unique work there at the Camargo, which is one of the world references in the digestive oncology surgery. And my great friend, welcome here.
Thanks, João. Thanks very much. In the name of AC Camargo, BSSO, and HPB, I appreciate your invitation. Thank you.
Thank you. So, to present us the lecture tonight, Professor Scatton, which is a very close friend. We had the pleasure to be together back in time at Cochin Hospital in 1998. If you allow me to say some words in French, I'll translate at the same time. So, Olivier Scatton, c'était sûrement, sinon le meilleur, un des meilleurs internes. If he wasn't the top resident at the time, he was among the best ones. So his present career is no surprise to me. Sa carrière, au moment, c'est pas du tout une surprise, c'est la conséquence de sa façon d'être depuis toujours. So this present situation is nothing but the consequence of his attitude since the time of the residency. It was a pleasure for me to be with him and to be in touch all those years. Ça a été vraiment un plaisir de garder le contact avec toi depuis toujours. So, je te souhaite une très belle présentation sur le CHC. I wish you a very nice presentation on the CHC, on the HCC. And I think we are going to have a unique presentation with all those speakers and Olivier Scatton. Thank you. Merci, mon ami. Allez, on y va.
Obrigado, obrigado. Really, it's a pleasure to be here. You know, we have very close relationships with you, but with the Brazil in general. You know, Fabiano works with me for a long time now, has been with me for more than 10 years now, and it's a pleasure to work with a Brazilian surgeon. And it's a pleasure to be here today, and thank you again for your invitation. So I will share my screen now. Okay. Can you see my presentation?
Tout à fait, oui. Yeah.
Okay. So you asked me to speak around, I'm sorry, around 40 minutes. So I will discuss just the minimally invasive surgery for HCC and dealing especially with short-term outcome, but also to give a perspective about the bridge to liver transplantation and the long-term impact of laparoscopic surgery. So sorry. try to. So, dear colleague, I decided to divide this talk in three parts. The first one will be dedicated to the short-term outcome. And I will show you what is the state of the art with the international national experience and consensus meeting position. Then we move to redo surgery by lap. This is a valuable option. And I would like to stress on the textbook of outcome, which is a new matrix, and how this short-term outcome can translate into a long-term benefit. In the second part, I will discuss the place of the robotic surgery as compared mainly to laparoscopic approach, and give you what is expected by the consensus meeting, and also I will give you an example of a comparative study we made in PTA hospital. And at the end, in the third part, I would like to speak about the advantage of the minimally invasive surgery, prior liver transplantation, on the feasibility of liver transplantation, and I will show you our experience of the Paris group, which is mainly represented by Paul Brousse Hospital and PTA Hospital, and where we gather our results, and I will show you at the end of the presentation. So let's get started with the first part, which focus on the short-term outcome and where do we stand actually. Very recently, the laparoscopic approach has entered the EASL clinical practice guidelines. And now the laparoscopic approach is a small, very small box in the recommendation. Given that the laparoscopic liver resection for HCC has been shown to decrease blood loss, morbidity, and hospital stay compared to open approach without hampering long-term outcome, then they enter the EASL guidelines. And this advantage has been acknowledged in this recent update of EASL guidelines for the management of HCC. The recommendation to use the laparoscopic approach has been made also in the first Morioka consensus meeting in 2014 in Japan, and more recently in an international consensus guidelines in Southampton, where we discussed the place of the laparoscopic approach. I would like to stress on the fact that there is no randomized trial yet to provide evidence, but we are waiting in France to start our first randomized trial comparing open and laparoscopic approach for a single HCC. So these Southampton guidelines strongly recommend the use of laparoscopic approach for HCC, especially in patients having cirrhosis. And all the evidence that were used to write these guidelines are based on retrospective analysis, especially this very good systematic review from Syria, which gather more than 28 studies. Here are the results of this recent meta-analysis from Syria, Ruben Syria, who studied more than 28 studies, with including more than 10 patients. But please note that only 4 had a significant number of patients, more than 100. And here are the results of the short-term outcome in terms of operative time, hospital stay, resection margin, complication, blood loss, and transfusion. And when you see here the green, that means that there is an advantage for laparoscopic approach. So in both operating time, which is maybe the only marker that is not modified by lab, for hospital stay And for complication and blood loss and transfusion, there is a clear advantage on retrospective study to use the laparoscopic approach. A little bit more in detail in this meta-analysis of Maurice. There is a specific benefit of laparoscopic approach in case of underlying liver disease, especially for the occurrence of ascites and liver failure, which show that there is a beneficial impact of the laparoscopic approach as compared to open for these two post-operative outcomes, especially in cirrhotic liver. Here is the French experience from what we call AFC. This is the French registry. We gather all the case of laparoscopic resection in France. And as you can see, we here gather around 1,377 patients with HCC. You can see here the population. What we found is that R0 resection is good. And mainly this patient had HCC developed on cirrhotic liver or very severe fibrotic liver. We found that long-term follow-up was exactly comparable as open. And we can see here that the post-operative morbidity was not so high, and especially the higher one. And the mortality rate was as low as less than 2%, which is quite good. When we look at the meta-analysis, the multivariate analysis of factors to achieve the R0, we found that anatomical resection and lesion less than 3 were two which were significantly associated with very good R0 resection. But when we compare our results in this registry between benign lesion and metastatic liver disease, you can see here that the conversion rate was higher for HCC and that the morbidity was also higher, which means that in that case we have underlying liver disease that exposed to a higher morbidity, post-operative morbidity. So as compared to benign and to metastatic liver resection performed by laparoscopic approach, conversion was high, especially for posterior segment and for major hepatectomy. So this is the French registry. We just published recently this series of more than 2,002 and almost 300 patients. When we look in details in our population, we just published in the BGS last year the impact of cirrhosis on laparoscopic resection, and clearly cirrhosis remains the main risk factor of mortality, irrespective of the expertise of the center or the expert or not center. It's true for severe complication, which is higher in a low volume center, but also in high volume center when you have cirrhotic liver. And the mortality was also higher in case of cirrhotic liver in low volume center or in high volume center. Even it's decreased here with the expertise. The difference between cirrhotic liver and non-cirrhotic liver was significantly different. And when we look at the multivariable logistic regression about the severe postoperative complication and the mortality after laparoscopic resection, we found a really major resection as a risk factor, cirrhotic liver, and also as a score as really significant risk factor for complication. And here in this property score analysis that compare almost 300 patients in each group with non-cirrhotic and cirrhotic patients, we found that the mortality was significantly increased in case of cirrhosis, as well as the severe complication rate, and especially the postoperative ascites and the postoperative failure. When we look at the ICU, it was also a little bit higher in case of cirrhotic liver, and as well at the duration of the hospital stay. So clearly, even by lab, the cirrhotic liver remains the main risk factor for postoperative mortality. So now let's move to the second part of this first chapter about the redo surgery by laparoscopic approach. In that field, there is very few data. Only 5 studies stress or focus on the role of redo or repeat laparoscopic liver resection. But you can see that only one of these studies is focusing only of HCC. The other one are mixed between colorectal liver metastases or colorectal liver metastases and HCC. So overall, the message is the same. There is less bleeding, less mortality, morbidity, and less hospital stay with similar long-term outcome. What we can see also is that the conversion rate, which is quite low, 4%, was not really analyzed, but is likely to be minimized after a previous laparoscopic resection done by lab as compared to open. When we perform here, they perform the propensity score analysis. What they found is no difference in terms of mortality between open and lab, no difference really in terms of morbidity. The only variable which was quite different was the duration of the operation was quite a little bit longer by a laparoscopic approach as compared to open. When we look in details of long-term outcome, we can see there is a trend in the subgroup analysis for only the subgroup of patients who had undergone an open procedure previously, showing difference between survival between open and lab. So there is a trend of better survival in patients who had a laparoscopic approach for redo surgery. But really, it's a weak evidence. This is an illustration of 2 cases we performed in PTA. One is a laparoscopic resection on the left lateral segment, and which with a recurrence more than 5 years after. Here you can see that there is very few adhesion and no adhesion with here the abdominal wall. You can more easily control the inflow, and you will see that we can do a redo laparoscopic approach by lap. Here is the resection is performed without clamping. And you can see that we can perform the resection as we can do with no previous surgery. In that case, this is recurrence after a TACE PVD and a right hepatectomy performed 6 years before. Here you have the recurrence in the left lung, and you will see again in this movie that there is very few adhesion. There are no adhesion with the abdominal wall, and you remove very easily the adhesion here. Here is the tumor, and you will see that you can approach the pellicule more easily. This is the artery, which and here the portal trunk, we can be dissect free and tape in order to clamp and to do the clamping and to do during the resection. Here, 2 clamps are applied in, and the resection is performed under intermittent clamping. So you can see that even after a procedure like that, right hepatectomy following TACE PVD, you can do a redo surgery by laparoscopic approach. So now we move to the last part of this first chapter, which is the textbook outcome, which is really a new matrix and very relevant one. And you will see how a good or better short-term outcome may translate into a benefit in terms of long-term outcome. So just to remind you that what is the textbook outcome? The textbook outcome is a new matrix that gather all the ideal short-term outcome. This is the better outcome in a given patient, in which gather several clinical outcome: negative margin, no transfusion, no complication, no mortality, no prolonged hospital stay, and no admission. And when you have gathered all these post-operative or perioperative markers, or you get what we call textbook outcome. This is the best outcome you can have after a resection. In this study we made with 5 other HPV centers, which gather early HCC on cirrhotic patients, we showed that laparoscopic approach increase the chance of textbook outcome. Here, for example, you move to, as compared to open, to 31 to 44 patients. And this influenced the quality of surgery in early HCC patients. And when we look at the impact of the textbook outcome on long-term outcome, you can see here that the TO increases the statistical cure fraction of patients. That means that a really good short-term outcome may translate into a better long-term outcome. So what is the best oncological scenario is to have a laparoscopic approach and the textbook outcome achievement. And that leads to the very best long-term scenario. This is also true for early HCC developed on patients who presented with portal hypertension. Here, this paper from Azoulay and Scatton, which shows that the laparoscopic approach was a predictor of liver decompensation, which was in the prevention, I mean, and it was also predictor to achieve textbook outcome, the TO. And when we have laparoscopic approach in patients with early HCC and clinically significant portal hypertension, there is a clear benefit of laparoscopic approach to achieve a TO and to have less post-operative liver failure. So now I will share with you our recent experience. It's not published yet. We will present it in HEALS Congress very soon in New York. And we gathered the case of laparoscopic right hepatectomy, or HCC, following a sequential maneuver of TACE and PVE. This is a multicentric analysis of TO, especially in only 5 French centers, and we gather 117 patients who had previously TACE portal vein embolization. In 41 cases, the laparoscopic resection was done by LAP, while 6 cases were done by open. So the goal of this study was to assess the short-term outcome, and especially the proportion of TO achievement and the impact on long-term outcome. So when we look at the population here, we can find there is no really difference between the laparoscopic group and the open group regarding the gender, BMI, the causes of underlying liver disease. The only difference were related to the tumor size, here only 1 millimeter difference, and the microvascular invasion, as well as the level of alpha protein. So this population was good to compare the short-term outcome, but not the long-term, because it was quite different in that case regarding prognostic factor of HCC. But this is the reason why we made later propensity score analysis to compare the long-term outcome. So when we look at the laparoscopic groups compared to open, what we found is that the operation is longer performed by lap. There is clearly no difference except for operating time in favor of operative or open group. But when we look at the outcome, we can see that the hospital stay was really significantly shorter when the laparoscopic approach was used. This is clearly a benefit for the patient to have the resection done by laparoscopic. More interestingly, when we look at the TO completion, you can see here that the laparoscopic approach was significantly associated with the TO completion, especially because there is no prolonged length of stay in the group of laparoscopic approach. And we compare here the complete TO, comparing here open to here lap, and you can see that the TO is more often completed when the laparoscopic approach is performed. And when we do a multivariate analysis of the cause and the prognostic factor to completion of the TO, here the laparoscopic approach and pellicle clumping were two significant factors associated with the completion of the TO. So we compare after that the impact of the TO on the long-term outcome and the impact of the laparoscopic approach on long-term outcome. To do so, we need to perform a propensity score matching to evaluate the long-term outcome benefit or not. And then we do this matching regarding all the factors which were involved, especially microvascular invasion and tumor differentiation, tumor size, etc. So we obtained two groups which were comparable, 27 patients by lap and 28 patients by open. Here you can see that now the size are exactly the same, microvascular invasion was the same, and so on, no difference between the two populations. It was comparable, and then we can move to a long-term assessment. So here is the long-term results and prognostic factor before and after PSM. You can see that the curve of survival, the overall survival and disease-free survival were strictly similar, irrespective of the use or not of the laparoscopic approach. So when we look only on the approach, there is no clear benefit of the laparoscopic approach in that setting, in that population of patients. However, when we look at the impact of the TO completion, you can see that the survival, overall survival, was clearly significantly different and beneficial for patients who complete the TO. And as you saw before, the TO completion was associated with laparoscopic approach. So this is an indirect benefit of laparoscopic approach by achieving more frequently TO completion that translate into a better overall survival. And when we look on the multivariate analysis, we found two very interesting factors associated with the better survival, which was the degree of liver, fibrotic liver, and also the TO completion. However, when we look at the disease-free survival, there is no difference between those patients who achieved the TO and those who did not. So this recurrence-free survival is really related to pathologic or tumoral factor and are really not dependent on the post-operative outcome. This is really logical to find that. But what we found, which is also logical, is that the transfusion rate and the surgical margin were significantly associated with the disease-free survival. So in conclusion with this series, which is not published yet, is that the feasibility of the laparoscopic right hepatectomy after a sequential treatment of TACE and PVV is possible. The laparoscopic approach was more frequently associated with the TO achievement or completion, and that the completion of the TO was correlated with a better overall survival. That means that, very importantly, a very good short-term outcome may translate into a better long-term outcome, which is really a new message within these new metrics. And last, when we look at the meta-analysis regarding the long-term outcome that gathered all the retrospective study, you can see here that there is no advantage or no disadvantage offered at 1 year, 3 year, or 5 years overall survival of the use or not of laparoscopic approach for a single lesion, child A patient, minor resection only, or major resection only, which is not really assessed because there is no enough patient to assess that. But we just saw in the previous study that in case of major, we have clearly potentially an advantage in completion to complete the TO outcome. So now we move to the second section of this talk, which is the robotic laparoscopic approach. As for laparoscopic approach, there is an international guidelines of the robotic liver resection. As you can see here, it was published very recently in World Journal of Gastroenterology 2019. The level of evidence is quite very low, 2C, 2D, 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 which means that really we should be cautious with the conclusion of all these international guidelines. There are some meta-analyses regarding the robotic versus open liver resection. And when we look at the series, we have only 10 studies between 2014 and 2018. And you can see that only 200 patients were included in this analysis with HCC. So this is very small experience with robotic surgery and HCC. More recently, there were a systematic review that gathered 10 studies with more than 300 HCC patients with robotic liver resection. Among all these series, 3 studies compare robotic to open, 2 studies compare robotic to 2D laparoscopic approach, and no series here compare 3D laparoscopic approach to a robotic surgery. We will see later that we made this comparison in PTA hospital and in Italy too. The portal hypertension was not specifically studied in this review. As for laparoscopic approach, here you can see that the R0 resection is very close to what we obtained by lap open, that the DFS and the OS were quite good at 1 year, 2 years, and 3 years, and as well for DFS and OS. So clearly there is an advantage of minimally invasive surgery, irrespective of the type. I mean, robotic or lap is still a mini invasive surgery. I would like to stress on 2 studies. The first one is a comparison between robotic hepatectomy for HCC to laparoscopic approach in 2D. The paper was published by Scatton very recently in World Journal of Surgery, and they compare robotic group for 42 patients to 72 patients resected by 2D laparoscopic. To compare the long-term outcome, they made a propensity score analysis matching And after matching, before and after matching, for both overall survival or disease-free survival, there is no difference between robotic resection and laparoscopic resection. Maybe there is a little bit more anatomical resection performed by robotic, and the margin were exactly the same between the two cohorts. So clearly, it seems very normal. There is no difference between laparoscopic approach in 2D and a robotic approach for HCC in these comparatives. So I would like to share with you our experience of robotic surgery compared to laparoscopic surgery, but mainly 3D laparoscopic surgery, because for now more than 6 years, we perform all the laparoscopic resection using 3D vision. So I will present you now our experience, comparative experience of 3D compared to robotic hepatectomy. So we are really very beginner with robotic hepatectomy. So we compare the experience of Pisa and Créteil-Henri Mondor experience by robotic, and we compare our experience in 3D. So you know that in addition of the ultrasonic assessment, the optimal vision is crucial to achieve the double objective of resection. Number one, to be corrective with a safe surgical margin, and number two, performing the parenchyma sparing resection to prevent postoperative liver failure. So there is no series comparing 3D that had been published so far. So we decide to compare the short-term and long-term oncological outcome of a series of 3D resection with HCC and robotic hepatectomy for HCC. So we published our experience last year. This is here the flow chart. So we compare the 3D minimally invasive hepatectomy between 2011 and 2017. Here in the laparoscopic 3D group, again, the series began in 2015. Almost 30 patients compared to 44 patients resected by robotic device. Just to summarize the specific technical feature of each technique, here you have the ergonomy, which is clearly an advantage of the robotic device with articulate tools. The 3D vision can be seen by the operator in both groups, laparoscopic group and robotic, but the 3D vision is only possible in case of laparoscopic liver resection as compared to robotic, because the other screen and the other monitor is in 2D. Here you have the possibility to use a flexible camera endoscope, which is very good to see in deep position, especially the superior and posterior segment of the liver. You don't have this by robotic, you have a 30 degree, 0 degree. The instruments are in favor here of robotic because you have articulate forceps, but you have more device in the laparoscopic group, especially the use of Cuisa is possible with robotic, but not through the robotic trocar. And the advantage is also for the laparoscopic approach, the use of very good and modern energy device. So don't bother too much with this table. All the data, proprietary data regarding the patient characteristics, the disease, and the staging of the tumor was equally were similar in 3D group and in robotic group in this here you can see that the operative time was in favor of the 3D laparoscopic resection as compared to robotic for only major, but for minor was exactly the same, as well as for anterior segment and as well as for superior and posterior segment, one segment, which are difficult segment, but the operative time was quite similar between robotic and laparoscopic approach. What about the margin? The margin were strictly similar in both groups, irrespective of the position of the tumor. What we found is that the Pringle maneuver was used more liberally using the 3D laparoscopic hepatectomy, and which translates in a lower transfusion rate in case of laparoscopic approach. Here you can see that the blood loss was increased in case of robotic surgery. Even there is a trend of more major hepatectomy performed by laparoscopic approach. When we look at the post-operative outcome, you can see there is clearly no difference regarding the mortality, the overall morbidity, especially the severe one, which was quite similar between the two groups. So this is still minimally invasive surgery, irrespective of the approach. I mean, laparoscopic or robotic, that means that the outcome is also similar. And when we look at the long-term outcome, there is clearly no difference between 3D and laparoscopic group and robotic group. So no impact on long-term outcome by the robot or the laparoscopic approach. So in conclusion to this only published series of 3D comparing robotic, that the 3D laparoscopic and robotic surgery achieved similar operative times, but with less bleeding and more clamping by lap, honestly. Short-term outcome was similar. Surgical margin were strictly similar, and there is no difference in terms of long-term oncological outcome. So now we move to the last part of this talk, which is the bridge to liver transplantation. I will show you, I think, really the advantages of the minimally invasive surgery on the liver transplantation feasibility, and also results, where it's very new results, recent results. And I will show you an experience of the Parisian group regarding this feasibility and the result and the impact of laparoscopic approach on liver transplantation. So as you all know, a large proportion of patients will recur. Even the overall survival is good. The disease-free survival is decreasing regarding and given the persistence of the cirrhotic liver. So the patient is exposed to recurrence, and this recurrence can be treated by either reduced surgery. We saw that in the first chapter of this talk, and now we speak about the salvage liver transplantation, which is an option in case of transplantable recurrence. In 2009, Henri Mondor Hospital, the group of Daniel Cherki and Alexis Laurent report the first experience of laparoscopic resection prior to liver transplantation, comparing laparoscopic approach to open approach. And this was a very, it was the very beginning, only 10 patients in each group. And what they found, only with these few patients, is that the liver transplantation was done quicker, with less bleeding, with lower transfusion rate, especially in phase 1 LT, which means the explantation. So here is the laparoscopic group compared to open group, and what was different was the length of duration of the operation, less blood loss, less bleeding, and a quicker operation. But the outcome was strictly similar. More than 10 years after that, we gather our experience between Paul Brousse Hospital and Pitié, and we looked at our cohort of patients who were resected before liver transplantation. It was around 300 patients. And after exclusion of patients for other type of previous surgery or ablations, we were able to compare 170 patients. 120 were operated by open, while 50 patients were treated by laparoscopic. 7 patients were converted to lap, so we were able at the end to compare 43 patients resected by laparoscopy as to compare to 127 patients who were resected by open surgery. You can see here the result in the laparoscopic group compared to open group. What we found is that the transfusion rate was lower in case of laparoscopic group, that the adhesion were less heavy in case of laparoscopic group. Here is the classification of the adhesion. Type 0 is no adhesion, type 3 is tight adhesion. And you can see that laparoscopic prevents from severe adhesion. And we also found that the length of stay in ICU was a little bit shorter in case of laparoscopic resection performed previously by laparoscopic approach. When we analyze the predictive factor of intraoperative transfusion during laparoscopic approach, we found three main factors. Here, as an illustration, you can see a patient who had previously a right hepatectomy performed by LAP following a TACE PVD. Here is a case of a left hepatectomy performed by LAP, and here is an atypical resection in 7-3 by LAP. Here you can see that there is very few adhesion, which is consistent of what we found in this series. So when we look at the factor associated with intraoperative transfusion, we found the May score over 15, which was a factor that increased the risk of blood loss. But we found that the protective effect of laparoscopic resection on the risk of intraoperative transfusion. And we found that when the adhesion were very severe, more than 2, score 2, then it was associated with an increased risk of intraoperative transfusion. So clearly there is a benefit of doing the first resection by LAP. It should be in a strategy for your patient. When you envision a liver transplantation, you should envision to perform the first, if you can, resection by laparoscopic approach. And even recently in this Italian registry, where they compare the role of salvage liver transplantation using or not the laparoscopic approach or open approach, they found after a comprehensive score matching that the minimum invasive liver surgery was independently protective factor for risk of delisting in an intention to treat analysis. This was also a protective factor for post-operative death and HCC recurrence. And when you look here in this patient after PSM, you can see that the patient survival was quite different when the patient has here laparoscopic liver resection previously. So in conclusion to my talk, I would like to give you some take-home messages. I hope that I convince you that the resection of HCC performed by minimally invasive surgery allows number one, a better short-term outcome, and especially the achievement of a better textbook outcome. A better outcome and feasibility of redo surgery for recurrence. That robotic surgery is probably feasible and will probably achieve the same results as that. But maybe tools are urgently needed and are really required to be at the same level as laparoscopic resection. I'm really convinced that the 3D vision might be recommended in the future for the laparoscopic liver resection. I hope that you saw that redo, the advantage of redo lap, and I show you 2 movies showing that you can do it and that you will benefit from the advantage of laparoscopic approach, even in patients with redo surgery. And I would like to stress on the last point, which is the really the good impact and the positive impact of laparoscopic resection to facilitate the liver transplantation that lead to less heavy adhesions, lower transfusion rate, and probably better outcome of the patient following liver transplantation. Thank you. Okay, can you see? Okay.
So, Professor Scatton, thank you very much indeed. As I said before, a unique presentation, very up to date. And it was very, very interesting, especially because you're showing non-published data, very recent to us. So thank you very much for everything, for all the review and everything, and the congratulations for the marvelous and fantastic activity that you have at the PTA Hospital. So now I'm going to open to the other speakers to start the questions and the debate with you. And well, we have like 25 minutes or so. Okay, thank you very much once again. Thank you all the attendants, and thank you all the speakers that are here once again.
Thank you, Joel.
So, Marcelo?
Felipe, do you want to start? You or Tafarel?
Okay. As a clinician, maybe it will be easy for me. First, congratulations, Dr. Nicoluzzi, for the meeting, and Dr. Scatton for the presentation. Made some points here that I learned about the robotic hepatectomy and the comparison between it and laparoscopy. So, as I said, as a clinician, we learn a lot with this kind of meeting. But I want to highlight some points, not just related with your presentation, but related with the hepatocellular carcinoma, and basically what some points that we are facing here in Brazil and maybe worldwide. When we talk about it, we know that the mainstay of therapy is surgical resection, as you show us. But great part of these patients are not eligible because of tumor extent or underlying liver disease, especially in our public health system here in Brazil. And I guess that we receive more advanced patients after COVID pandemic. And why I'm saying that? But first, we are not performing the 6 months screening in this population who knows that have cirrhosis, because the patients don't go to the outpatient clinic or don't schedule the exam, and we'll see mortality rise in the future. The second, we are receiving less patients with recent diagnosis of cirrhosis. And if we don't diagnose cirrhosis, we will lose hepatocellular carcinoma, especially the early stage of HCC. And it's something that you point in your presentation. It's very important. We diagnose early stage of HCC. And the third, it's another new point for us in worldwide. We don't know if these patients would develop liver dysfunction due to COVID, such as the PSC-like manifestations, will develop cirrhosis in the future. And maybe we have this answer in the next year. So my first question is, what is your opinion about it? The effect of the pandemic in the early diagnosis of HCC?
Yes, you're totally right. We face exactly the same situation, I think, worldwide. The screening is not so good, even in France. We know that it's cirrhotic, especially alcoholic disease is a well-known disease in France, but the screening is not so good. You know, in the Chang study, the Chang study aims to assess the screening, and only 30% of the patients were really screened for early HCC during the follow-up of the cirrhotic liver, so the disease. So we have very, very bad screening of the disease and the risk of occurrence of early HCC. So the proportion of early HCC is small. And when we look at the algorithm in the treatment, the curative treatment is really a small box. Still in France, it's only maybe less than 1/3 of patients are eligible for a curative treatment, either by liver transplantation, ablation, or resection. And the vast majority of patients have advanced disease, advanced HCC or advanced liver disease. But we are thinking with, with the Barcelona group algorithm, and there are a lot of other algorithms, especially from Asia. We are, which gather experience from surgeon and hepatologist, which is the main difference with the Barcelona criteria. Just reminder, it's only 2 hepatologists who wrote the guidelines at the beginning without any. It's just a nightmare to be a surgeon in Barcelona, I think so, but it's my opinion. But now it changed. But and in Asia, they gather expertise of surgeon and hepatologists and radiologists, and it's more open to discuss the patient. And they go a little bit far, especially with thrombosis, portal thrombosis, dealing with or bilobal liver disease. So they operated more patients with advanced disease. And recently, there is this randomized study comparing TACE and resection for multilobular HCC, showing that the surgery have an advantage over TACE. So we need really to push the limits for surgery. This is my opinion. I'm a surgeon, but I think that we have some evidence for that. And yes?
I agree with you when you talk about that, because when we analyze the BCLC staging system, we have this negative point, in my opinion. The fact that they stand that only patients with 3 nodules up to 3 centimeters should undergo liver transplantation. Mm-hmm. And it isn't what the Milan criteria says. So it's important to open the mind and analyze it as a big picture, not just as a small picture. I'll follow this small box and that's it. It's what I think.
And regarding the COVID, we just reassessed our result of surgery following patients who had COVID previously. And we found that there is a higher mortality, even after the patient has cured from COVID. So we are very cautious with this patient. And we wait for longer time before going to surgery. And maybe we have a tendency to do more TACE or other treatment to have a long delay between the diagnosis, the COVID, and the surgery. This is the tendency we have here in France. And I totally agree with you. The screening is less efficient with the COVID. The patients are not referred to the centers. Now we have the patient have more severe cirrhotic decompensation and more severe HCC. They are referred with maybe 6 or 1 year delay.
Thank you, Dr. Scatton.
You're welcome.
So congratulations, Professor Scatton. I'm really impressed with your huge experience and in minimally invasive surgery. And I'm very impressed with good results as well. I have a question for you. I really did understand why you show us that you have more Pringle and less bleeding in laparoscopic group, because it was a surprise to me. We have a few cases in robotic surgery, but seems to me that you have a less bleeding. And what are you feeling about that? I
think we are at the very beginning of this experience. So what I show you is very beginning experience, and it's also a comparison between 2 centers with 2 policies. I mean, for me, clamping is not an issue. So there is no problem with intermittent clamping. For a long time. This, for me, it's not really an issue now, so I never hesitate to clamp. And it translates into less bleeding. This is the reason why. The second one is, you know, by robotic surgery, even you have a good ergonomy with the articulate tools, you don't have so many energy devices. The energy devices which are very efficient are still in the box of the laparoscopic surgeon and not available for robotic, but it will come soon. So I'm really convinced there is no really a debate between robotic or laparoscopic approach. There is a debate only to provide minimally invasive surgery for that patient, especially if you envision a strategy, a global strategy, resection before LT or sequential redo surgery. So what is very important is to bring a less invasive surgery to the patient, irrespective of the type of mini invasive surgery.
Good. Well, the second question is, you have a very good results with redo surgery in laparoscopy. But when you have recurrence in cirrhotic patients, when you look for long-term survival, we think that liver transplant is better in terms of long-term survival. So in your group, how do you select patients with recurrence to, you know, you can do a liver resection again, but how do you select liver resection or liver transplant today?
It's a huge debate. And yes, it's, I think there is two options. The theoretical option is to do a liver transplantation because you can achieve the best theoretical treatment for the patient. But it's not always the most practical treatment. So I think that, for example, in our center, we used the salvage liver transplantation in case of recurrence. If the HCC at the beginning has a very good prognostic factor, I mean, pathologically. So in that case, we can use the liver transplantation as a salvage solution. But when we have bad prognostic factor on the resected specimen, then we run for the principal liver transplantation before recurrence. But it's not always possible. And you know, in France, HCC is the man who is 70 years old, and they are not really, they have a very few access to liver transplantation. So this is the reason why we perform redo and redo, because of the age, because of the availability of the graft, etc. Okay. But ideally, I would like to transplant everyone, but it's not possible. So we have to deal with this, with that.
Good, good.
And Marcelo, what is your policy in your center?
Well, we do some case of liver resection when we can, but we are more comfortable today to do a liver transplant. We have a wait list time about 6 to 8 months in São Paulo for HCC. Sometimes you have to wait more for sometimes with blood type A and O. But we have nowadays we have a very good neoadjuvant therapy, and our dropout is slowing. It's not big, so we can be you can do more liver transplant. Okay. It's not exactly the same in all parts of the country, but in my group we prefer to do a liver transplant. I mean, in recurrence HCC. Mm-hmm.
Okay. Professor Coimbra.
Oh, okay, thank you.
We didn't forget you.
Oh. Thank you again for the invitation, John. And thank you for the very nice presentation, Professor Scatton. Very nice, I really enjoyed it. And congratulations for all your work presented here tonight. And so I have maybe one or two comments, two questions, and at the end, I'd like just to discuss with you a case, very simple case, I think. So, so the comments I'd like to make would be, I like it very much the TO completion as a prognostic factor, let's say like that, because I think it's an indirect measure of a quality of surgery. So, so this is the first comment. I'd like to, and congratulations for the idea. I think this is a very nice initiative. And actually, there's one more question I just forgot, but what's the expectation and what did you reach in your study? So what would be the good percentage of TO completion for HCC, like 30%, 50, 70? I don't know if you have this answer yet, but I'd like to know.
We don't have really a threshold, but the higher is the best. So, but honestly, this new matrix is really interesting because it's a global view of the advantage of minimally invasive, but it's the best outcome in a given patient. And we all know that bleeding and transfusion may translate into worth outcomes. So it gives you really a nice view, overall view of what can be a good surgery, a good outcome may translate to a good long-term outcome. And really, I don't know how long it will be useful comparing open to lap, because honestly, if we will perform a randomized study next year in France. I'm not sure TO completion will be very different between open and lap, given the evolution of open surgery and lap. But it gives you the global idea that the best, the short-term outcome is the best is the long-term outcome. This is the main message, irrespective of the approach, I mean.
Yeah, very nice. And I would only suggest if you could take a look, like instead of only seeing like the total completion, you may have even a score. For example, you did 4 of the 9 of the 10 completion items, 5 or 7. I don't know. May you have a different result here.
So a TO is really, you have to gather the 6 criteria.
Yeah.
All the 6 criteria is the TO completion.
Yes, very nice. Ines, and 2 questions on the minimally invasive surgery in the liver, in all those upper segments, 7, 8, and maybe 4A. Do you ever use thoracic approach? In which case and how you do it?
Honestly, never. Before laparoscopic approach, I used to do a small thoracotomy for a lesion in the upper part of the liver when I envision a liver transplant. To avoid any adhesion. But now, as you saw, I hope in some movie, there is no adhesion following a laparoscopy. This is something really incredible. And you know, I do with the Mets, I do a lot of 2-stage hepatectomy, and I'm still amazed by the very small adhesion we found between the 2 procedures. So now with the laparoscopic approach, no need for a thoracotomy to approach the upper part of the liver. But you're right, reaching the upper part and posterior part of the liver is really tricky by lap. And I don't use transthoracic trocar because I don't like it. Maybe the robotic surgery will be more easily with the, with the ergonomia will be better to do that. I'm convinced that the robot will bring us to this more difficult part of the liver. But I'm afraid there is still a lack of tools for me because I use always CUSA, so I'm not comfortable with the robot without any CUSAs or energy device like that. Yes. So when we will have the new tools, and we will have it very soon, I think we can achieve more complex case in upper part of the liver.
Yeah, and I think especially maybe there's a role a bigger role for patients with like multiple abdominal surgeries, for metastases and other things. That may be a role in those situations, but very selective patients.
Yeah.
And another technical question. Do you ever use like arterial clamping instead of, for cirrhotic patients, instead of Pringle, and when you use it?
Not selectively. I always do, intrafascial approach for major. Mm-hmm. So I divide first the pedicle before transection, but honestly, I do the Pringle, intermittent Pringle, and not only artery or portal vein. A new way for me, we will try this year to perform some, it's unusual, but to try to put some tips before patient had clinically portal hypertension prior surgery. And then in that case, you removed the opposite part of the tips, and you just clamp the artery. We perform this only 3 cases to start. Mm-hmm. And maybe it will be a new way to overcome the portal hypertension. And okay. If we are able to do that before, I know it's unusual to put the tips when you have a HCC, but maybe there is a room for some patient to treat it by tips. You can remove it after if you want to close, I mean not remove, but close the tips if you have any encephalopathy in the postoperative course. But I think that maybe it would be a new way to expand the indication.
Yeah.
And then you have just to clamp the artery.
Thank you. Yes, thank you. And I wonder, with this new data, of course, there's lacking a lot of data for this situation, but do you ever discuss on your tumor burds or like very specific situations, maybe multinodular tumors, or even a suspect of extrahepatic lymph nodes, for example, neoadjuvant treatment for some patients already? And which situations have you used it?
For multiple lesion, we used to do a neoadjuvant therapy. We try TACE, but mainly radioembolization to screen, the natural history of the disease. And then if it's stable or if we have a response, we go to the surgery. It's unusual too, but we try to. And which is now, I think the best option would be the patient who received, the Beva and Atezo-Beva, yes. The combination before. Obviously, maybe after there will be a benefit, but before for multiple nodal, it would be an option, yes. I think we have to put in the HCC more oncological strategy that we have at the moment. And we should bring from oncological field a little more for HCC.
Yes, I agree. And so just to finish with the case, so what would you do? So child A, HCC, 1 lesion, 4 centimeters, 4 or 5 years old patient for HBV. What would you do, 4 or 5 years old in this situation? Would you resect it? It's resectable, of course, or indicate transplantation?
My institution is resection first.
Okay. Yes, because
we switch from transplant resectable patient to resect transplantable patient.
Yeah. Okay. Yes. And the other situation would be the same patient with 75 years old, but I think you already answered it, right? Yeah. Thank you. Okay. Thank you very much, Professor.
You're welcome.
Thank you.
Well, I'm not supposed to ask you a question, but I cannot avoid, well, I was very curious about the article that you showed from Paul Bruce concerning resection under high portal pressure. Yeah. So I just would like to know, I didn't know that paper, being very honest to you. So which are the limits of the high portal hypertension that you take to indicate resection or transplantation once because it's something that we normally here in Brazil, we most of the time we use it as condition to indicate transplantation once the patients are under Milan criteria.
Yeah, this is a very tricky question, actually. Now, there is debate of defining portal hypertension.
Yeah, that's it, yeah.
And how you will assess as a surgeon. And in our center, we made this choice to systematically have the pressure, get the pressure for all the people we have to operate. But honestly, I'm more confident in the stiffness than in the pressure. And so we try to assess with stiffness, with the pressure, and with clinical signs of hypertension. I'm still don't know really how to assess portal hypertension. Some cases are obvious, you know that it's too high for surgery, so you get straight to liver transplantation or ablation. And sometimes you don't really know when the platelet count is 100, when the size of the spleen is not so much, and there is no really esophageal varices. So, and then stiffness may be useful to decide if you are going to surgery or liver transplantation or ablation. And it's a daily practice debate. I mean, during the meetings, what do you think the degree of portal hypertension? And in some case, when we have no choice, for example, for all people, that the only alternative is surgery, then we can go maybe with a modulation of the portal hypertension, somatostatin, tips, etc., to modulate what I would say a moderate portal hypertension, not a high hypertension, but moderate. And obviously, we try to do it by lab, because I'm convinced that is in this setting of patient that you are really beneficial with minimally invasive surgery, with less ascites, less liver failure, etc.
Yeah, yeah. Jean, Marcelo?
Yeah. Are you using radioembolization for neoadjuvant therapy? Yeah.
Sometimes, yes. More and more.
And what are your experience with transections of the parenchyma after radioembolization? Because we have some case that you find a very rude fibrosis. Mm-hmm. You know, after radioembolization, the patients had ascites after surgery. It's not very easy to do
Was it for large HCC?
Yeah.
Yes. Maybe
for colorectal liver metastasis as well.
Yeah. For very large HCC, maybe you have an impact on obviously you have an impact on the parenchyma. I have no enough experience to say if it's really different or not. I know that now the techniques has really evolved. At the beginning, there was some embolization of the artery, of the gastroduodenal artery. Now it's not like that, it's very selective. And so they improved the technique, so it's better now, even for liver transplant, I mean. But I have no enough experience to give you really a message or something relevant.
Okay.
Você tá mudo, João, acho.
Thank you. Jean, would you like to ask another question? Or Felipe? Because I have some questions from the chat, because people who are watching us in YouTube, they have some questions.
Jean Tafarel is a French name.
Yeah, it's a French name, but I'm from an Italian family. I was born in Brazil.
Okay.
I don't speak French, but it's a French name. Yeah, yeah.
So I have one question from Rafael Garcia. one of our colleagues who is attending the course. So he excellent lecture regarding pre-operative planning. Use only the volumetry of the liver or use another method like ICG retention, scintigraphy, or another one? How do you prepare your patient to check the reserve? That's the question.
We gave up with ICG. Mm-hmm. We don't have expertise anymore. And honestly, it's a pity because I love it. But we gave up with the ICG. So this is totally different in Asian countries, where this is the first step with the ICG. For me, it's a biological assessment with the liver function, volumetric assessment, and stiffness. This is the three main type of evaluation.
Mm-hmm. Okay. What do you guys use in São Paulo, Marcelo, Felipe, to check the reserve of a patient to prepare him to before a resection, cirrhotic patient, HCC? How do you check if this patient is eligible for resection or not?
We are using volumetry, and some cases we are using ICG, but we don't have a very experience. And now we are starting a study with MRI, with a pathologist. It seems to be very useful.
Totally agree. We try to compare the stiffness by MRI and the stiffness and try to correlate the liver stiffness by MRI, which is maybe a new good tool. Because you have a overall view of the organ, not only focus on the parts of the organ.
Yeah. We use basically volumetry. And of course, if there is a previous PVE, we also use the dynamic growth, the atrophy of the liver, the total volume and everything. And also the relationship between weight and liver volume, so as well. Okay. But basically, the most important would be volumetry.
And the second question that I have to the speakers: do you measure the portal tension or not? How often do you do it?
Always by transjugular approach. Always perform a measurement of the pressure. Mainly, I would say, for academic reason, more than to try to find really the relevance of this measurement, but it's too variable.
Before surgery or during the surgery, Professor?
Before, always before, and with the biopsy. And during only by open, honestly. Take the pressure at the end.
What about in São Paulo, Felipe, Marcelo?
We don't.
Do you measure? No,
we don't.
Yeah, we don't do, because when you have a portal hypertension, you prefer to go to the liver transplant.
I have another question. So Olivier, so you said during your presentation about resection as a bridging.
Yeah.
Does it change your where you're planning bridging to liver transplantation, depending on the histological specimen that you have sometimes? Does it change your plan of bridging this patient up to the transplantation, depending on the findings that you have sometimes or not?
Absolutely. You know, I've done this work when I was in Cochin, because I was very interested in the prognostic factor in histological factor, yes. How the specimen can be used as a tool to decide the strategy for salvage or de principe liver transplantation.
Yes.
So what now I'm convinced that when you are in Milan criteria, when you are within, when you have bad prognostic factor, you can go directly to liver transplantation. And when you have very good prognostic factor and you are in Milan criteria at the beginning, you can wait for salvage. There is no risk to be outside the Milan at the recurrence when you have a good prognostic factor at the beginning. Why? Because the screening is very good in this patient who had the resection. They are screened every 3 months with imaging. So you know that they are really, the follow-up is very nice. So when you have a good prognostic HCC, histologically, I mean, you can follow it. And if there is any recurrence, ablation, redo surgery, or liver transplantation. In the other situation, you have bad prognostic factor, but you are within the Milan criteria at the beginning, go through directly to the liver transplantation, not waiting for the recurrence because the recurrence will be outside the Milan criteria. And last, when you are outside the Milan criteria at the resection and you have bad prognostic factor, for me, it's a contraindication for liver transplantation because you have more recurrence after that. This is our vision in PTA.
Yeah, and it's still related to this question because we have many students that are attending this course as well. So it might sound like quite a basic question, but I don't think it is. Which are the findings in these resections that you do that you fear the most for the patient? When you resect this patient that you're thinking about bridging him and comes this specimen, what fears you the most for the patient when you check the specimen?
You know, the vascular invasion, which is maybe the worst prognostic factor.
Okay. Yeah.
Which is sometimes correlates to the alpha fetoprotein levels. And by the way, in France, you know, we use the alpha fetoprotein score rather than the which combine biology of the tumor and size of the tumor, number of tumor. And if you are up to score more than 2, we don't go to liver transplantation. We have no graph for that. It's not a contraindication, but there is no allocation for this high-risk patient.
And do you consider for those patients outside Milan or high levels of markers liver-related transplantation?
Never, because we have very less and less experience with living donors in France, and I don't like to take a risk for a donor and a recipient with a very hazardous results for the recipient. I'm more keen to do downstaging using neoadjuvant radioembolization, atezobeva, whatever you want to downstage the patient and bring him to the transplantation.
I see. Yeah, I think in Brazil we are not allowed to perform use cadaveric graft for patients outside Milan criteria.
Okay.
Where some places they can do liver-related, but if the patient has arterial thrombosis, they cannot use a cadaveric graft. Then that's the point.
When we are outside, we use the DCD in France, and we use the split liver transplantation.
Split?
Yeah.
Split.
Yeah. And when you use biopsy before decide to liver resection or transplant?
Very good question. Should we biopsy the liver before? This is a very good question. I think that we have to do more and more biopsy to decide. Especially because, for example, when you have a case of very small central HCC on the right part of the liver, when you have the choice between ablation or resection, here is the discussion on what is the prognostic of this patient, the risk of the surgery, etc. So really, I would prefer to do a biopsy, ablation, and wait for that kind of patient, rather than doing extended resection, even by lab. And so we need to biopsy more and more patients to get prognostic factor to decide the strategy of that. I think that you agree with me. There is no really risk of dissemination with the biopsy now. Nowadays, there is no issue with the biopsy. In the expert center, I mean.
Yes, I agree. Because we are not comfortable with Milan criterion. You know, sometimes you have a 5.1 centimeter. You are outside of Milan, but you have a well-differentiated HCC, and you,
I absolutely agree with you. This is the reason why now we have the alpha fetal score in France, because you can have a tumor, unique tumor more than 5 with a very low level of alpha fetal, and you can get a graft for that. And sometimes you have 2 small nodules with 1,000 alpha fetal protein, and you are outside. You are in Milan, but you are high risk of recurrence.
Yeah, sure. And you have some level of alpha fat protein to do a liver transplant in Paris?
Yes, we have so 3 levels, 2 threshold, 100, 1,000, and it's 1 point, 2 points, 3 points. And you know that in France, more than 2 points, you have no graft. So if you have, for example, 100 alpha fetal protein with a small unique nodule, it's okay. But if you have 2 nodules and 100 alpha fetal, you don't have the points to get the graft.
Wow.
This is what we call the French score, or the alpha fetal protein score. We validated it too in Italy very recently. We think that it brings you a little bit more biology to the science. It's improved Milan criteria.
But you can put this patient in the neoadjuvant therapy.
Yes, absolutely. In case of downstaging, you can re-enter the transplantability and then transplant the patient.
Good.
Any more questions? Well, it's 1 a.m. Actually, 1:30 in Paris.
It's okay.
Je sais. Merci de toute façon. So, well, I think we try to keep this like 1 hour 15, 1 hour and a half, our lecture. So the presentation was far beyond our expectation, because not only we talked about the laparoscopic and robotic resection, but much more than that. The screening, like Jean said, and the other doubts, the cases that Felipe and Marcelo said, and the other questions concerning transplantations as well. So thank you very much indeed. Thank you very much. Next time, I hope to see you in Paris.
I hope so. I would like to come in Brazil, yes, too, you know.
Yeah. Well, we're catering it here.
Pleasure to come back in Brazil. Yeah.
And I also would like to thank you to everybody who's been attending all these conferences every Monday. And thank you to the speakers, Dr. Coimbra, Dr. Marcelo Bruno, and Dr. Jean Tafarel, for being with us tonight in the level of the question, and for their large experience here in Brazil that are making a difference as well in our reality.
Thank you so much.
Merci.
Obrigado a todos.
Obrigado. Thank you so much to give me the opportunity to meet all these very nice people. Thank you. Hope to see you in Paris or in Brazil, all of you.
Okay,
sure.
So thank you again.
Thank you.
Have a nice evening. Bye, everybody. Thank you again.
Bye.
Thank you. Bye-bye.
Bye.